Your vagus nerve fires a chemical brake onto your heart roughly 800 million times in a lifetime. Every single heartbeat is slowed by it. Acetylcholine floods the sinoatrial node, the heart's pacemaker, and pulls the rhythm down, a constant invisible restraint that keeps the organ from racing itself to death. But in millions of cardiac patients, that brake has gone quiet. After a heart attack, the vagus nerve's output to the heart drops measurably, sometimes by half. The medical term is cardiac vagal withdrawal, and when that withdrawal becomes permanent, it is one of the strongest predictors of whether a patient lives or dies. Patients with severely depleted vagal tone face up to 4 times the mortality risk. What we're going to do right now is trace exactly how this nerve controls your heart rhythm. Watch what happens when it fails, and follow the clinical evidence showing how specific interventions are waking it back up. The vagus nerve is the longest cranial nerve in the human body. It leaves the brainstem at the medulla, threads through your neck beside the carotid artery, and branches into every major organ in your chest and abdomen. But its most immediate, most measurable target is the heart. Here's the mechanism. The right vagus nerve terminates directly at the sinoatrial node, that tiny cluster of cells in the upper right atrium that generates every heartbeat. When the vagus fires, it releases acetylcholine. That acetylcholine binds to muscarinic receptors on the pacemaker cells and opens potassium channels. Potassium rushes out, hyperpolarizing the cell membrane, and the next electrical impulse takes longer to reach threshold. Your heart rate drops. Not dramatically, not dangerously, just enough. This is vagal tone, the continuous parasympathetic pressure on the heart that keeps the rhythm slow, stable, and efficient. Think of it like a hand resting gently on a spinning wheel, applying just enough friction to keep the speed steady. Remove the hand, and the wheel spins faster, wilder, less controlled. A comprehensive review published in Wiley Online Library laid out the full scope of this mechanism, a systematic analysis of vagus nerve stimulation's theory and evidence across cardiac and systemic disease. You can actually measure vagal tone. It shows up in your heart rate variability, the tiny fluctuations in the time between consecutive heartbeats. A healthy heart doesn't beat like a metronome. It speeds up slightly when you inhale, slows down when you exhale. That oscillation is called respiratory sinus arrhythmia, and it is driven almost entirely by the vagus nerve. A Frontiers publication dedicated to psychophysiological research methods confirmed this. HRV, specifically metrics like RMSSD, the root mean square of successive differences, is a validated, reliable index of cardiac vagal tone. In a healthy person, HRV is high. The waveform dances. In a heart failure patient, that waveform flattens. The vagus nerve has gone quiet, and the heart is left exposed to sympathetic overdrive. Adrenaline and noradrenaline pouring in without opposition, driving the rate up, constricting the vessels, demanding more oxygen from a muscle that is already struggling. And here's where the damage accelerates. After a myocardial infarction, the autonomic nervous system undergoes a process called autonomic remodeling. The sympathetic nerves that survived the infarct zone sprout aggressively, but the vagal fibers, thinner, more delicate, retreat. The balance tips hard. And it does not tip back on its own. A Frontiers study on comprehensive autonomic evaluation confirmed that HRV isn't just a laboratory curiosity. It serves as a clinical cornerstone for predicting recovery in cardiac and stroke patients alike. The heart is now running without its brake, and the consequences are about to compound. Once vagal withdrawal sets in, the heart enters a self-reinforcing loop. Without parasympathetic restraint, resting heart rate climbs. Elevated heart rate increases myocardial oxygen demand. The already damaged heart works harder, remodels further, and the sympathetic system interprets the declining output as an emergency, so it pushes even more adrenaline. It's like a thermostat that detects the house is cold, cranks the furnace to maximum, but the furnace is cracked and leaking heat. The thermostat never gets its signal, so it never turns off. This is the hemodynamic spiral of chronic heart failure. And the missing piece, the component that standard cardiology has been slow to target, is the vagus nerve. But here is where the science took a turn that surprised even the researchers. The vagus nerve does not just slow the heart, it suppresses inflammation. Through what's called the cholinergic anti-inflammatory pathway, vagal efferent fibers release acetylcholine in the spleen and other organs, which inhibits the release of pro-inflammatory cytokines, tumor necrosis factor alpha, interleukin-1, interleukin-6. These are the same cytokines that flood the bloodstream after cardiac injury and drive the chronic, low-grade inflammation that destroys surviving heart tissue over weeks and months. When the vagus goes silent, the immune system loses its off switch. The inflammation doesn't resolve, it smolders, and the heart muscle pays the price. A curious, systematic review connected this same autonomic dysfunction to pathways linking chronic pain conditions with coronary artery disease, showing the vagal deficit isn't isolated to one organ system. So the question becomes, can you turn the nerve back on? Researchers at Frontiers tested exactly that, mapping how different auricular vagus nerve stimulation sites and protocols produce measurable changes in autonomic responses. The ear, specifically the tragus and cymba conchae, contains a branch of the vagus nerve called the auricular branch of Arnold. Stimulate it with a small electrical device, and the signal travels up into the brainstem, reaching the nucleus tractus solitarius, the same relay center that receives signals from the heart's baroreceptors. The brain responds as if the vagus nerve itself had fired. Here's something worth thinking about. Have you ever noticed your own heart rate variability? Maybe through a fitness tracker, maybe through a stressful night where you could feel your pulse pounding irregularly. Does your heart feel more chaotic at night or in the morning? What the clinical data showed next changed the trajectory of heart failure research. The ANTHEM-HF trial implanted vagus nerve stimulators directly onto the cervical vagus in patients with reduced ejection fraction heart failure. Over 6 months, patients showed measurable improvement in left ventricular ejection fraction and significant gains in HRV. The nerve wasn't dead, it was dormant, and with chronic low-level electrical nudging, it began firing again. A randomized controlled trial published in Nature tested a less invasive approach, post-exercise auricular vagus nerve stimulation in previously sedentary adults, and found that even transcutaneous stimulation modulated autonomic recovery responses measurably. The implications rippled outward. A Frontiers study on transcutaneous vagus nerve stimulation in breast cancer patients demonstrated something broader, that vagal stimulation engages neuroimmune pathways capable of improving quality of life across serious medical conditions, not just cardiac ones. The cholinergic anti-inflammatory pathway was no longer theoretical. Stimulate the vagus, and TNF-alpha drops, interleukin-6 drops. The inflammatory cascade that was devouring surviving cardiac tissue begins to quiet. The heart, for the first time since the infarct, has room to heal. And the interventions aren't limited to electrical devices. Slow, deep breathing at approximately 6 breaths per minute, 5 seconds in, 5 seconds out, maximizes respiratory sinus arrhythmia. Each long exhale stretches the baroreceptors in the aortic arch, triggering vagal afferent signals that feed back into the brainstem and amplify parasympathetic output. It is mechanically a manual way to squeeze acetylcholine out of a nerve that has forgotten how to fire on its own. Cold water applied to the face activates the trigeminal vagal diving reflex. Heart rate drops within seconds, peripheral vessels constrict, vagal output surges. This is measurable, reproducible, and requires nothing more than a bowl of cold water. A scoping review in Curious confirmed that even conventional hypertension treatments produce measurable shifts in HRV, reinforcing that vagal tone is modifiable across multiple clinical pathways. An umbrella review of meta-analyses published in Nature's Translational Psychiatry found that abnormal HRV appears across mental and physical disorders alike, positioning vagal dysfunction as a cross-diagnostic marker, not a cardiac specialty. A Nature systematic review further documented that cardiac autonomic control measured by HRV is significantly impaired in major depressive disorder, tying the heart's vagal brake directly to the brain's emotional circuitry. This is the neuroplasticity of the vagal cardiac axis. The nerve adapts. It weakens with disuse and damage. It strengthens with stimulation. The heart doesn't just wait passively for its brake to return. The entire circuit from brainstem to sinoatrial node remodels in response to input. Every deep breath, every cold exposure, every precisely placed electrical pulse tells the medulla, "Fire the vagus," and the medulla listens. The vagus nerve was never gone, it was waiting for a signal. Right now, between this heartbeat and the next, your vagus nerve is either holding the line or letting go. That gap between beats, that flicker of variability, is the sound of a nerve deciding how hard your heart has to work. Next, what happens inside your brainstem during 60 seconds of controlled panic?